allergy, asthma, and immunology. So those are all well earned. Jeff has a special interest in asthma, but this morning we'll be speaking to us about a topic that I, as an ID physician, receive questions from patients about with great frequency, and that is environmental mold and their impact on human health. So Jeff, thank you so much for being here.
Thank you. I've been hoarse for a little while, and it's actually better today. I would like to know if you could hear me loud enough.
With the mic, it seems fine.
Great.
That's okay.
Thank you. So yes, what I want to talk about today is mold, the truth information about it, and also a lot of mythology. That if you're not really keeping up with it, it's hard to tell how much of it is real and how much is just hype. So the objectives, you'll be able to describe the effects of mold on allergy and asthma, describe the health associations of living in dampness and mold, review allergic bronchopulmonary mycosis and hypersensitivity pneumonitis, describe the new sort of concept of severe asthma with fungal sensitivity, distinguish the effects of mycotoxins, which depend on their route of delivery, and review the misconceptions. And so the agenda is going to be many of the things I just told you, some of the mycology and some of the mythology. And I'll go through all of the facts, and towards the end, I'll talk about the things that patients often hear about, or people come to me with and say that they want to sue their landlord, and here's a mold report. And the second part is going to be remediation and what it actually does. So the major medical effects of mold are allergy and hypersensitivity, infection, they're toxic ingestions, and to a certain extent irritation by the microbial VOCs emitted by mold. The controversial aspects are going to be the so-called mycotoxin inhalation disease, toxic mold syndrome, sick building syndrome, acute infantile pulmonary hemorrhage, chronic sinusitis, neurologic symptoms caused by mold exposure, and immune disorders supposedly caused by mold exposure. The hypersensitivity part of mold is this part, of course, that I deal with the most. You get rhinitis and asthma, occasionally hypersensitivity pneumonitis, ABPA, which you all probably know, and we often call it ABPM because it's not just Aspergillus that causes it. Allergic fungal sinusitis, atopic dermatitis, which turns out to have a connection to the Malassezia yeast to a certain extent. And so the mold waiting room is going to be somebody with asthma, rhinitis, hypersensitivity pneumonitis, and ABPA, as you can see. I hope this isn't going to be too prosaic. There's a lot of lists, and I've tried to keep them just to the minimum, and there's no reason really to try to commit them to memory. These are the molds found in housing environments. The primary one is Aspergillus and Penicillium. We group them together because without doing the culture, morphologically, if you look at it under a slide, they look identical. Cladosporium and Alternaria are the two major molds that you'll find in American air. And I'll go on to explain that they have a connection to dry asthma. Stachybotrys it's found in about 13% of homes, and it's not abnormal, and it's not as dangerous as it's put forth to be. So you might remember memorizing tables when you were in medical school about the 4 kinds of hypersensitivity. Type 1 is where an IgE combines with an antigen that causes histamine release. And the disease is associated with that allergic rhinitis, allergic asthma, allergic bronchopulmonary aspergillosis, and and allergic bronchopulmonary mycosis. Type 3 is the antigen-antibody complex, and that actually becomes important in hypersensitivity pneumonitis, and apparently in aspergilloma, although I won't be addressing that today. Type 4, which is the delayed kind of hypersensitivity, and I should really just go to the next slide. Oh, there we go. The next slide. Type 4 is sensitized lymphocytes will recruit other lymphocytes to go and attack the antigen. The common examples that you've seen are a mosquito bite. It takes about a day for it to start to get itchy, or poison oak. Okay, I'm going to go from mold to talking about dampness. There was a pivotal study done in 2004 by the Institute of Medicine, and its title was Damp Indoor Spaces and Health. It's a very long document with several appendices, and without the appendices, it's 332 pages. I'm going to give the conclusions of that study, which are significant. But I want to say that the Institute of Medicine is in a certain way a democratic institution. And so not only were physicians on the committees to make recommendations, but representatives from the building contractors, trade union, and education, or school boards, excuse me. And every word kind of had to be finessed so that every group was okay about it. So it's a slightly political document. However, the CDC did a very good job, and they just cut down to a few easier bites. Sorry about that. And what they say is they divided their analysis up into evidence for the association of just being in damp indoor spaces, and there is sufficient evidence to show that there are more upper URIs or URIs. There's more cough in homes where there's dampness, more wheezing, and asthma symptoms in people who are already basically asthmatic. There's less and less evidence that there's more shortness of breath, or that there could even be development of asthma in persons who don't already have that. And they came out and said that there is really not enough evidence at all to say that acute idiopathic pulmonary hemorrhage in infants even exists as a result of this. Now, has anybody heard of that disease or know why it came into play? I'll talk about it later, but in the 1990s, a group of babies in Cleveland developed acute pulmonary hemorrhage. And there was some association with the fact that their homes had Stachybotrys in it. And so there became really a panic that Stachybotrys was a mold whose mycotoxins would float through the air and could cause hemorrhage in children. Thank you. And that's subsequently been disproven. So we've just talked about damp environments. Environments where you have mold, there's a lot of overlap, but you could see that there's also occasionally hypersensitivity pneumonitis. There tends to be more just respiratory illnesses where kids go to the doctor more without having asthma. And they went through all the things that there aren't really enough evidence for. So the bottom line for this is that when there is mold and dampness, there are more lower respiratory symptoms and upper respiratory symptoms. The way they define mold and dampness is very, very loose. So some of and these are done through meta-analyses, some of the studies would qualify if there was standing mold in the house or standing mold in the basement, or if you saw a few dots of mold on the bathroom ceiling, or said that there was some mildew on clothes. So this wasn't extremely rigorously validated, verified. It turns out that living in dampness is extremely prevalent, and without going through all the entire slide, it turns out that On average, in the United States and Canada, 40% of people are living in homes that would be considered to have mold and dampness, meaning that 47% of the people are kind of at risk for these respiratory conditions. William Fisk is a researcher at Berkeley, the Lawrence Berkeley lab, and has looked at a lot of epidemiology regarding mold and dampness and outcomes. And he's calculated a few outcomes and what the odds ratio of developing them are. And so what you can see here is a slide on the left, the odds of developing bronchitis, odds ratio of developing bronchitis by living in mold and dampness is, you can see the sign, it's almost 1.5%. The odds ratio of developing any respiratory infection is also increased. And I can't tell whether it shows in the slides. Whoop, there's a major line here for the lung, and you can see that to the right of it is where the odds ratio average for these conditions are. So the main line and this not very visible red dotted line. Now I've talked about the mold and dampness, and sort of maybe out of the blue, but they're important because fungus plays a great role in the possibly the development, but also the intensity and persistence of asthma. It's been shown that people who are allergic to fungus have increased risk of developing asthma. That's probably obvious. Their asthma is worse. Their pulmonary function tests are worse compared to other asthmatics, let's say, who are not allergic to fungi. They have greater hospital admissions, and there are more asthma-related deaths. This is one of the most prominent molds in fact, it is the most prominent mold we have in North American air, and it's called Alternaria, which is Alternaria. And you can see that the reason it's called that is because when you look at the spores, they have these, it's almost like bricks being laid at a certain offset. There's alternating cells. Dr. Fisk, in another one of his studies, looked at the chances of developing asthma in living in any home that had mold or dampness. I'm going to come back to the Alternaria. And he found that the general increase is 30% greater chance of developing asthma if you are growing up in a house with mold and dampness. This is another representation of the same thing, and you can see that to the right of the number 1 is the increased odds ratio. Cladosporium, I'm just throwing these in because these molds will come to play. Cladosporium is the second most common mold. The name clado, I think somewhere in Latin or Greek, means club, and they kind of look like clubs. So I've told you that at least in North America, Alternaria and Cladosporium are the 2 most prominent molds that we have in outdoor air. This is a study from Europe where they just looked at what's the odds ratio of somebody who has Alternaria allergy or Cladosporium allergy to have asthma, not necessarily to develop asthma. And as you can see, the odds ratio is it's 2.56%. The range is 1.49 to 4.40. In other words, it doesn't cross the number 1, which means that it is a significant increase. Now, this is actually a pediatric study, or a pediatric longitudinal study, where they looked at children and saw what happens if they're allergic to various dust mites or molds, and what are their chances of developing asthma in later life. And they list, several of these, but the yellow highlight comes down to if you're allergic to any mite, like dust mites, you have a 1.74%, or you have a 1.74 odds ratio of developing asthma. If you're allergic to any mold, it's 2. So what I'm trying to express here is that mold allergy seems to be important in developing asthma. If it starts with the allergy itself, without asthma in childhood, there's a good chance it will develop into asthma. Another one of these studies where they looked at individual molds, and what they found is if you take children at age 6 and look at what's their chances of developing asthma if we know that they're allergic to certain allergens. If you take Alternaria, which is right here, I don't really know whether people can see from these tables. Basically, you have a double chance of developing asthma when you're age 22. This is a study from Europe where they looked at people who were admitted for asthma once and looked at the same people if they had multiple admissions for asthma. And I'm just going to go to the bottom line of this. These are different studies of what people are allergic to. And, people without admissions have in the range here of, up to 16%, some of them will have mold allergy. People who are admitted for asthma once have basically the same range, but people with more than one admission for asthma, and I think that this is within a year, have a substantially higher chance of being mold allergic. Now, they have a substantially higher chance of being allergic to cat and dog, but the difference between one admission or even no admissions, just being asthmatic and being hospitalized several times, is more characteristic of what happens with mold allergy when it's added. To further point out the association of molds and intensity of asthma, there's a study that was done in Chicago, and the researcher took the plot of pollen counts, the plot of mold counts over the year, and then plotted asthma-related deaths. And I am sorry that these curves are not clear enough to see which is which, but the important point in there is that you get more deaths when the mold counts are higher. And I guess what they're saying here is if the mold spore count is greater than 1,000 spores per meter squared, there's 2.16 odds ratio of actually having a death from asthma. This study was done in Minnesota, and it kind of shows the same thing. But I want to bring out a point about it. We think of molds as occurring in damp environments, and everything I was just telling you about was the implications of living in dampness. I also said that Alternaria is the most prevalent mold in the United States, and also that Alternaria seems to have a special role in being associated with asthma. In the Midwest, in the summer, when the hot winds are blowing, and actually when it's dry out, that turns out to be the time that outdoor Alternaria counts reach their peak. In this study, what Dr. O'Halloran did was he retroactively looked at respiratory arrest in young people and plotted it against the Alternaria mold season. There are two curves over here, the one to the left, which is solid, and then the one to the right, which has open circles. And what that represents is, in terms of the mold in the air, on the left side are just actual Alternaria spore counts, but on the right is the molds disintegrate and you won't find it as a spore count, but if you measure the amount of the major allergen, which is called Alt-A1, it's high. And you can see that during this alternaria season, there were more respiratory arrests. Have people heard of asthma phenotypes? Concept that came into play, I guess, about 15 years ago. Not all asthma is really the same disease, and one way of saying it is that there are several different asthmas. And this is with the original paper that kind of described it. Because the slide was so faint, I kind of had to put this in myself. The top is childhood asthma, and the bottom is adult asthma. And the severe asthma is kind of an overlap between allergic, occupational, post-menstrual, and non-allergic. Some things weren't mentioned. For example, we consider that obesity is probably a different kind of phenotype for asthma. In some sense, severe asthma with fungal sensitivity is going to be another one of the phenotypes, although it's not in that list. Now, we've all heard of allergic bronchopulmonary aspergillosis, a serious disease, tons of mucus, very high eosinophil and IgE counts, and eventually bronchiectasis and fibrosis. Before that, though, there's a new concept that people who have severe asthma and are positive to fungi are their own class and are possibly on a spectrum leading towards ABPM. The criteria for diagnosing severe asthma with fungal sensitization, or SAFS, it isn't that difficult. It's a severe asthma, positive allergy test for any mold, and you have to rule out that the person doesn't have ABPM. You don't have to memorize anything or take this into great detail, but this is a slide just describing what do we define as severe asthma. This is the American Thoracic Society's definition. There are major and minor criteria. I just want to point out that anybody who cannot be treated with less than high-dose inhaled steroids, so in other words, Flovent 220 or Advair 500, is considered severe asthma. Of course, it could be more severe. You could require corticosteroids all year. But that's basically an operational definition. The global initiative towards, I forgot what the N is, asthma, or GINA, has its own definitions for what constitutes persistent asthma, moderate persistent, and severe persistent. And just these are the criteria. The important thing is that if you've had more than 2 courses of prednisone in the last year, or your FEV1 is less than 60%, or you're having asthma nightly, any of them classifies you as having severe asthma. And so that's how the patients who are called SAFS must be diagnosed. That's the criteria for having severe asthma. Don't get too concerned with this one either. However, this is what the classic criteria are for ABPA, allergic bronchopulmonary aspergillosis. The major things in it, or the major points, are that the IgE has to be more than 1,000. The eosinophil count has to be more than 1,000. They have to have a positive allergy test to aspergillus, and they need to have positive IgG anti-aspergillus antibodies, which are also called precipitons. There's a few other criteria. You can see that it's much more severe than the case of SAFS. But the current concept is that the asthma will kind of march from just asthma to asthma with fungal sensitivity to the severe asthma with fungal sensitivity. This is one form of ABPA, and this is the most severe with central bronchiectasis. Th1 and Th2 are the 2 kind of phenotypes that you'll find in lymphocytes. Th2 is primarily allergic and releases cytokines that are IL-4, IL-5, and other pro-allergic cytokines. Th1, which is more immune and anti-infective, secretes interferon gamma and other kind of anti-allergic cytokines. So the greater the Th2 profile, the more you're likely to develop ABPA. This is an algorithm which, the only reason I put it up was to kind of show the things that you look at to see whether somebody has severe asthma, fungal sensitivity, or ABPA. And the main difference that you could see on this slide, where this breakpoint is, if it's ABPA, the IgE level is greater than 1,000, and if it's severe asthma with fungal sensitivity, it's not 1,000. And then there are more trickle-down signs and symptoms. It also turns out that treating people, not with ABPA, but with just severe asthma with fungal sensitivity, treating them with antifungals has a beneficial effect on their asthma. There aren't too many studies showing this, and some of them are mixed with studies on ABPA. This shows a 48-week study where subjects with SAFS were given itraconazole and various parameters were measured. Whoa. The AQLQ is the Asthma-Associated Quality of Life Questionnaire, which is considered a validated questionnaire. There are a few of them in asthma to determine the activity of asthma in a person's life, and it went up by about 16%. The IgE level in these people went down. The FEV1 didn't change, and the peak flow changed a little bit. But basically, the person's perception and their IgE level went down. This is another study which looks at, it's kind of mixing patients who have the severe asthma with fungal sensitivity and patients who have ABPA. The solid lines are the ones with fungal sensitivity. And you see that there are benefits in each of these parameters looked at. And so this is just a table to say what I've just told you, that you could just have asthma, you could have fungal allergy, or severe asthma with fungal allergy, or in the more extreme, ABPA or ABPM. This is a photomicrograph of Aspergillus fumigatus, which is the cause of most ABPA that we would see here. And one question that comes up, let's see, is can you get ABPA by working in an environment that has a lot of Aspergillus in the air, or living in a house that has high Aspergillus counts? And the answer is probably not. It doesn't seem to come from point exposures. There are case reports, for example, men who work in a compost company having a case report of them having ABPA, and case reports of people, for example, working in making soy sauce, in which they're exposed to sort of clouds of a different Aspergillus orsii, but there are no actual studies, no controlled studies looking at whether their risk is greater than the general population. One of the main reasons that we thought that there isn't point exposure importance is that people who live in rural environments where there's a higher exposure to Aspergillus have the same incidence of ABPA as people living in an urban environment where there's less. In parentheses, there's one unpublished study from India that shows maybe people in a rural area have higher incidence of ABPA. But the thing is that it doesn't seem to be from point exposures. This becomes important in, unfortunately, medical legal cases where someone may have ABPA and have mold count done on their house at the say that, well, it's cause and effect, or mold count done in their working environment. There are multiple immunogenetic associations. The most well-known one is that HLA, DR2, or DR5 increase the risk of developing ABPA. And you can see that these higher numbers for the ABPA patients versus the lower numbers for those who don't. And DQ2 seems to have a protective effect because it's much higher in patients who don't have ABPA. There can be several slides of all the different SNPs and other genetic findings, but I think that for our purposes, this is the most important one. And this, again, says that it's more disposition rather than exposure. I was using the term ABPM because ABPA, which we're all used to, doesn't just come from Aspergillus. It's been reported with many other fungi, and this is a hard slide to get, but it's a copy of a copy. But you can see that Candida is actually a cause of ABPA or ABPM in several cases, and basically most of the other molds that we have around, much less than Aspergillus, though. The pathogenesis of ABPA or ABPM, which I'll go into really quickly, is everybody can inhale spores, but sometimes these spores will germinate in mucus, and that will set off the immune system, where there's a very strong allergic type 1 response and an antigen-antibody reaction, which leads to larger amounts of mucus, inflammatory infiltrates. This induces high IgE and high eosinophil counts. There tends to be mucus impaction, decreased airflow in certain areas, and ultimately a central bronchiectasis will develop. Central is defined as the inner 2/3 of the lung. And here you can kind of see bronchiectasis in the center of the lung. These are just different heights of slices. Again, I told you that there are classic criteria for ABPA, but Dr. Ritesh Agarwal, who is one of the foremost researchers and publishers in ABPA, has come out with a much more simple criteria. All you really need is to have an IgE that has to be over 1,000. You have to have an allergy test that shows that you're allergic to Aspergillus or whatever the mold is, and then two of the of these criteria, either the precipitating antibodies, pulmonary opacities, which can be fleeting at times, high eosinophil count, or the central bronchiectasis. But it's much simpler, and it also will include more patients in the definition. Patients with CF are at greater risk of developing ABPA, partly because they have a lot more mucus that doesn't clear very well, and also because of different genetic susceptibility. How would you diagnose ABPA in somebody with CF when they already very often have very high IgE levels? And the answer is, look, everything else is the same in them, but clinical deterioration, if this CF patient develops more wheezing cough, sudden worsening of their pulmonary function, and I guess if you've ruled out something like pneumonia, that can be criteria for ABPA if it's persistent. Treatments, I'm going to go through quickly, mainly steroids. Azole antifungals have been shown to be helpful, and that has only really come into the picture since the early 90s. Inhaled amphotericin B, and something that is a wonderful development is Xolair, because they have these very high IgE levels. You might also, if you've ever given Xolair, the product instructions say that it's not to be given to people with an IgE over 700, and these patients by definition are greater. I'll get to that in a minute. This is just one of many, many studies that I could show you. This one is giving voriconazole to ABPA FCF. And what this is showing is, okay, their pre-treatment levels of IgE are the red, their post-treatment levels are the gray. In other words, their IgE level came down with the voriconazole alone. And I'm going to skip the next half of that. Because the product insert for the label instructions for Xolair are only up to 700, there's special dosing recommended for people who have ABPA. And whereas the maximum you give for asthma is 300 milligrams every 2 weeks, this one is 600 milligrams every 2 weeks. And these are just some studies showing what happens if you put people on Xolair. This is a study from France where the annual number of exacerbations goes down, the consumption of prednisone goes down as a reflection of the intensity of the ABPA. This is a Spanish study that basically says the same thing in more prosaic form. Daily symptoms goes from 15 out of 18 patients to 8 out of 18 patients. Oral corticosteroids go from 17 out of 18 to 6 out of 18. And so I'm going to leave the topic of ABPA or ABPM and talk about allergic fungal sinusitis for a minute and not much more. It's basically the same concept as ABPA, except it happens in the sinuses. Does anybody know why I have that photograph there?
You're hungry?
First reason. The second, another reason? The reason is that the characteristic of allergic fungal sinusitis is that the mucus that's found in the sinuses is like peanut butter. It's always described as being the thickness and color of peanut butter. So, and that's due to the, it's probably due to the very rich eosinophil count. The fungi that cause it are Aspergillus, Curvularia, Alternaria again, Bipolaris, and some others. Not that important for this morning. Now this is from a Pulp Fiction cover that I happen to have. It's just I think a 1950s or 60s book called H is for Heroin. And this is very corny, but H is for heroin. HP is for hypersensitivity pneumonitis. Hypersensitive pneumonitis, which used to be called extrinsic allergic alveolitis, is a disease caused by inhalation of organic dusts. It could be caused by a number of things, such as bird droppings, bacterial products, but it's also largely from fungi. And the very small particles of fungi, less than 3 micron, can get down into the respiratory bronchioles and down to the alveoli. It induces an IgG response and then type 4, the delayed response. It is not a systemic disease at all, so it's really confined to the lungs. What are the fungal exposures that you could get that could cause this? And you might have seen tables in the past with just different professions and what kind of lung disease they develop. I'll just point to 1 or 2 that are interesting. People who work in the cheese manufacturer will develop it from penicillium. Penicillium is on the that skin you get on camembert or brie. It's also the wet coating of salami is penicillium. People making soy sauce, as I said before, are exposed to Aspergillus oryzae. And now this is penicillium, which is characteristically, it has this appearance of a paintbrush. And you can see the chlamydia over here with the spores that are going to be released. So getting back to the professions and some unexpected professions that could cause hypersensitivity pneumonitis, soy sauce making is an important one. People working in the cheese industry, as I said, and also people who work in a factory making Beano or any of the digestive enzymes that people seem to buy a lot. All of these are really fungal enzymes, especially Aspergillus niger, and you can develop an HP from that. Metalworking actually is another cause because the fluids that are used, for example, to keep the gears moving, become infected or contaminated with mold, and the workers have had cases of hypersensitive pneumonitis as a result. You probably remember when mifestatin came in, or mifestatin. These are actually drugs that are elaborated by fungi. And for example, when you get patients who take red rice yeast, are basically eating the mold that makes the statins. And this is just a list. Mifestatin is originally derived from penicillium, lovastatin from Aspergillus, Zocor from the same one that is in red rice yeast, and pravastatin from the nocardia, which isn't a mold. So there's a lot of different, there are pages and pages that you might have to memorize before taking an allergy board exam. Some of these that I just thought were funny or interesting. We all know about farmer's lung, which was the original one, and farmers who are forking moldy hay. It's actually caused by a bacteria. There's dog bed lung, where being exposed to or fluffing up dog bedding will give you Aspergillus. Misting fountain lung is an Aureobasidium. Sax lung is a sax mouthpiece that exposes you to Candida. Metal worker's lung, as we talked about before. Cheese washer's lung, which is penicillium. And sequoiosis occurs in people who are basically lumberjacks who are cutting down sequoia trees or redwoods. I'm going to kind of truck fast through some of these, it's not too boring. How do you make the diagnosis of HP? It's largely a clinical diagnosis. The patient goes into work and develops shortness of breath. If you take an x-ray at that moment, you'll probably see an infiltrate. You can find antibodies to the bacteria or to the fungus that they're responding to. The most specific is when there's more chronic HP is a CT scan that shows reticular or nodular or ground glass in the CT, and the bronchial lavage fluid shows a low CD4 to CD8. When they avoid the antigen, of course, they improve. This is just some of the slides showing that they develop a cellular bronchiolitis, which you can kind of see at in this bronchiole. They have non-necrotizing granulomas with multinucleated giant cells, and I think that kind of is an example. When chest x-rays are done, they often will have diffuse opacities, and sometimes they're enlarged hylar nodes. This is from an interesting case reported in the New England Journal, where something like a 9-year-old boy developed HP, and they tested it for lots of other diseases first, and it turned out to be from Aspergillus flavus, which was just growing in his house. This is CT showing the opacities plus hyaluronopathy. There are 3 stages of HP. You could just have it and go away from the antigen, it'll go away. If you have progressive exposure, you get more and more permanent lung changes. What is the treatment? Well, the primary one would be, as everything in asthma, avoiding the antigen, and they're treated with steroids. Slightly different conditions called, it used to be called silo filler or silo workers disease, organic dust toxic syndrome, which is frequently miscalled pulmonary mycotoxicosis. And what happens, someone is shoveling in a silo and they get a massive inhalation of fungi and endotoxin and other kinds of dirt and antigens, and they develop fever and shortness of breath. And it's just one of the inhalational fevers. I don't know if any of you have seen others. Common ones, metal fume fever for people who work in foundries. At any rate, it's very, very common in people who work in farming. And although it's called pulmonary mycotoxicosis colloquially, it has nothing to do with mycotoxins. Other effects of fungi, which I'm just going to briefly go over, is that people can get infections. As you know, even immunocompetent people will get surface infections from dermatophytes or pulmonary infections with Coxiella histo. And now I want to talk about mycotoxins. Mycotoxins are something that comes up in the media and people's concern a lot because they know that there are mycotoxins from fungi and they're afraid that if they have this fungus growing in their house, are they going to be exposed to it and what's the danger? If you ingest mycotoxins, you will usually have some sort of poisoning. They're considered a secondary metabolite by the fungus, and since fungi live in their food, these are enzymes that kill and break down the food that they're living in so that they can absorb it. There are many cases of people eating these with serious problems, and I'll show you later. I do want to mention that they have a relatively short half-life, which is hours to days, and there is no, they are not inhalationally acquired. So even if you have Stachybotrys or whatever mold that does make a toxin in your house, you can't really get sick from inhaling it. And this is a statement by the Institute of Medicine and the American College of Environmental and Occupational Medicine, saying that there is no evidence of mycotoxin inhalational disease. Big sleep, some of these are actually fatal. And big sleep might also describe how you feel when you see a table like this, but these are the more common mycotoxins, ergot alkaloids that could cause ergotism, aflatoxins that when they infect peanuts can contribute to hepatocellular carcinoma, etc. Over here we have one for Stachybotrys, which are trichothecanes. They cellularly inhibit the creation of DNA and RNA and protein synthesis, and people or animals that have eaten it will get hemorrhage, dermal necrosis, and blood diarrhea. So these are cases, as I said, of actual toxicity from mycotoxins. Ergotism, there's another one, alimentary toxic leukemia. People in Orenburg, Russia ate some food that was contaminated. Balkan nephropathy is sort of an endemic nephropathy around the Danube, and this is from eating ochre toxin. The animals that were reported to have eaten the trichothecanes from Aspergillus developed skin and mucosal disorders that were fatal. And there are reports that dogs being given dog food that has an overdose of aflatoxins that have died. Probably the mycotoxin that we know about the most, and that really is fatal, would be the amatoxins. And this is a representation of Amidiophyllades, or death cab, and beside it, which I think is right here, is the death angel. These really will kill you. This is a serious problem due to mycotoxins. This is one of many case reports that I was able to find accidental fatal aflatoxicosis due to hepatic failure, acute hepatic failure in 50 dogs. And it happens with some regularity. This is another Pulp Fiction book. It was a movie called It Ain't Hay. But actually, with the original problems with Stachybotrys, it was hay. It was contaminated hay. In the 1920s, in Russia, cattle and horses were fed contaminated hay, contaminated with Stachybotrys, and they developed these epithelial disorders, skin and mucous membrane inflammation. The reports are very vague: bleeding disorders and upper and lower respiratory tract disorders. Again, that's Stachybotrys, which is the mold that's brought up in so-called toxic mold syndrome. I was looking for spore pictures, and I found this website. This is from the Chemical Industries Research Institute, I think. And it seems, it's a trade industry, or it's a trade Association's website, educational website. And I noticed, well, some of the things that they were saying here about Stachybotrys were, just completely unfounded lies that get propagated. So far, I haven't told you about any immunologic or neurologic problems caused by Stachybotrys. Stachybotrys, which is colloquially often called the black mold, is actually between green and black at different times. And you may know that any mold can be almost any color at different times. Many of the other Deuteromycetes, like Alternaria, penicillium, can at times have mycelium of the color black. And of course, Aspergillus niger is called that for a reason, because it's black. They have very sticky spores that are very hard to get aerosolized. So I mentioned this a little bit before that I called it Russia, but the report said Russia, the Ukraine. It killed infected, it killed some livestock by ingestion. There were some unsubstantiated reports that farmers handling that feed had disease. But since 1940, no human case of actual Stachybotrys illness has been reported until the 1980s, when it was reinvented as either the fatal fungus or toxic black mold. These are the descriptions that I found on that industry website, and this is set up for the public and I guess also for professionals. And you notice that the qualities that they attribute to Stachybotrys are suppresses the immune system involving lymph tissue and bone marrow, which is completely unsubstantiated. I wish I had some pictures for this. What they did in vitro is just look at what is the effect of trichothekines on growing cells, and they inhibit the synthesis of DNA and RNA. They took mice and actually instilled the toxin up their nostrils and saw what happened. And they actually developed bronchoalveolar disease and pulmonary interstitial inflammation. But then they took the same mice, or not the same, they took mice and put them in the equivalent of a room whose walls were completely coated with Stachybotrys. And they increased the airflow to 4 times the normal and saw what happened to these mice where they were exposed to surface Stachybotrys. And basically it had no effect, including no problems with their bronchi or their lungs. Starting in about the mid-90s, the concept of sick building syndrome arose. There were office workers who complained of various vague symptoms, and mold was found in their buildings, sometimes Stachybotrys. One study showed that there was Stachy and also Aspergillus versicolor. Reports came out that these people had neurologic problems, digestive problems, etc., but none of them were really substantiated. These were just doctors, saying, I saw this person who complained that he was dizzy a lot. One of the studies, doctor diagnosis interstitial lung disease. However he did about the patient's symptoms, there's no physical examination even. So the symptoms that people say occur with sick building syndrome, I'm just going to go to the ones that I think are obviously wrong. Shaking, headache, focal weakness, dizziness, restless legs, memory loss, dysuria, mold variations, anxieties. I mean, this really has nothing to do with inhaling, or with mycotoxin, let alone inhaling. The media began to call Stachybotrys contamination the toxic mold syndrome, and it's actually the same symptoms as the sick building syndrome. However, there is absolutely no evidence whatsoever that mycotoxins cause either of these. And several studies show that there is sort of a psychosocial origin. Before I go on, and I won't discuss the pulmonary hemorrhage, starting in the 90s, very large jury awards were given to people who had homes that had Stachybotrys in them. The most famous, which I don't have a picture of, was a $72 million settlement by, I think, Farmers Insurance to a wealthy enough woman who had a house somewhere in Texas. There was Stachybotrys found. Her husband began to have problems concentrating, and ultimately they won this jury award. And this kind of created the momentum for concern about Stachybotrys and also for litigating against it. Changing the subject to volatile organic compounds, VOCs or microbial VOCs are the chemicals that actually give you the smell of mold. And so if you're holding a truffle and you smell it, you want to see if it's a really good one. You smell the mycotoxins. Having volatile organic compounds in the environment doesn't just come from molds, doesn't just come from bacteria, but actually housing materials themselves, dry drains, the HVAC system, and human beings. There are many kinds of them. I'm going to skip through these. This is a study of people's symptoms when they were exposed to one of the major MVOCs. And just to cut to the chase, patients were put in a room for, I think, 200 minutes, and they didn't notice any eye effects, any breathing effects, any concentration effects. There are reports, and probably valid, of irritation caused by MVOCs. However, it seems to be people might get a sore throat or feel that they need to cough. It's completely self-limited. There's no systemic aspect to it. It's strictly irritation. Immune dysfunction is often attributed to Stachybotrys, and there's absolutely no connection. There are tests offered to test you for Stachybotrys antibodies, which are also irrelevant because there is really no immune disease.
Dr. Davidson, I wonder, given the hour, if we should allow people to ask a couple questions.
Oh, great.
And if you'd like to, people may wish to stay and hear some of it. But I want to respect.
I'm sorry, I didn't realize
it's
the
fine, no worries. Firstly, any disclosures? Because we generally.
I'm sorry, I didn't mention, I
That's
have no
fine.
disclosures.
That's perfect. And other questions? It's a lot of material and a lot of mythology. I think that you've done a great job of debunking for us. Are there specific, David?
With molds and fungi being pretty much ubiquitous, everybody's exposed at some point. And with the statistics you gave in the beginning, should we call all our asthma patients back in, think about treating them with itraconazole? What type of workup should we do before we treat? Is it worth doing or is it not worth doing?
No, I think that if you have an asthmatic patient, it's reasonable or a good idea to send them to an allergist, and one of the things to look at is whether they have fungal allergy. But if they're not very sick and that they can be treated with regular outpatient therapy, they're fine. If they develop severe asthma and they have fungal sensitivity, one thought is to treat them with immunotherapy, and the other is possibly to treat them with antifungals. But it wouldn't be for routine use.
You'd reserve that for the more severe asthmatics who are harder to control?
Right, and it really is kind of a newer concept.
Other questions? Well, again, if anyone is able to stay, of course, we'd love to hear the remaining.
There's only about 2 more slides.
Okay.
This is one study of children who were discharged from pediatric hospital after an asthma attack, divided into 2 groups. One were given asthma education at home. The other were given asthma education, plus they did mold remediation in the homes. And the bottom line was, for the ones where there was no remediation, there was no significant reductions in asthma symptoms or ER visits. For the ones where the mold was remediated, there was a 33% reduction in asthma symptoms. Unfortunately, the Cochrane review, the Cochrane Institute, looked at this and didn't find such a compelling compelling result. They found for asthma, asthmatics living in mold that's been remediated will have less wheezing, less respiratory infections. Children will go to the doctor less, but won't change their asthma. And I think I could stop there.
Okay, well, thank you so much, Jeff. That was wonderful. Last questions? Only gratitude.